Hello, thanks for coming to today's video where we're going to be discussing high altitude illness. So we'll begin like always with a simple definition. So these are any syndromes that occur during or following an ascent. And generally we're talking about a mountain here. Primarily we're going to focus on three syndromes that do tend to occur with climbers. First is going to be the acute mountain syndrome, which is a general type of non-specific condition. These patients who are afflicted with this tend to just have some headache and malaise, nothing too much more than that. After this, we have the high altitude cerebral edema, and this is going to be an acronym for this is going to be HACE. And following this, the most severe form is high altitude pulmonary edema. So pulmonary edema, and the acronym for this is HAPE. Now, the difference between high altitude cerebral edema and high altitude pulmonary edema is high altitude cerebral edema is just a more severe form of AMS, whereas high altitude pulmonary edema occurs 2 to 4 days after the ascent, and it can generally be accompany AMS and HACE as well. So now let's go ahead and change our focus into looking at the physiological changes that occur as an individual is going up a mountain or just ascending. So what we need to do is we need to first look at how the oxygen is being inspired. So the amount of oxygen, so this is going to be the pressure of the inspired oxygen, is going to be equal to the fraction of the inspired oxygen. So this fraction is how much of the air is actually going to be oxygen, and this is generally right around 21%. Now this number doesn't change whether you're at sea level or you go up to the highest peak. It's always going to be 21%. Now this figure is then going to be multiplied by the barometric pressure minus 47 millimeters of mercury. So what is barometric pressure? This is also known as the atmospheric pressure or the pressure that's outside. So just to kind of use this formula at sea level, what's the barometric pressure? Well, at sea level, you have 760 millimeters of mercury. So if you go ahead and you solve this formula at sea level, you're going to get somewhere around 150 millimeters of mercury. So at sea level, you get the amount of air oxygen that you're inspiring is going to be 150 millimeters of mercury. But as you ascend, the barometric pressure slowly starts going lower, lower, and lower, and lower. And so as the barometric pressure goes low, as this decreases, so does that decrease. And so since you have a decrease in inspiration of oxygen, you're going to overall, the body's going to start reacting as if it's hypoxemic. And this is called, let me write it over here, hypobaric hypoxemia. So hypobaric hypoxemia is just referring to the fact that you have low oxygen because of low baric pressure. So how does your body respond? The response to this hypobaric hypoxemia is something called acclimatization. So what acclimatization refers to is the fact that your body is now experiencing low oxygen. It's going to start making physiological changes to increase that oxygen level that is deficient. So there's going to be two main responses, you can say. The first is going to be induction of the hypoxemia inducible factor 1 alpha. Hypoxemia inducible factor 1 alpha increases transcription factors, and this can activate more than 100 genes. And all of these genes are related to trying to increase that low oxygen level. So at the same time, we do have sensors, peripheral sensors in the aortic arch. So what I've drawn here to the right here is we have the aortic arch, which extends here. We have both of the carotid arteries here and also there, and we have the split up right here. So down here at the bottom, we have a collection of nerve ganglion that go up into the brain here. These nerve ganglions is called the aortic body. And at the same time, right at the bifurcation here, you have another set of nerve ganglion called the carotid body. So the initial response is going to occur from the carotid body and the aortic body. So let's write this down. Aortic body and carotid body. So what do they detect? Aortic body and carotid body, both of them together detect oxygen levels. And so what happens is, because you have decreased inspiration of oxygen, you're going to get low oxygen levels. And when they detect a low oxygen level, they're going to send a signal up into the brain to increase ventilation. And this is known as the hypoxic ventilation response. And so just a big word to say that whenever someone becomes hypoxic, the ventilation will suddenly increase, the minute ventilation. And so the individual who's this is occurring to will start to kind of just breathe much quicker than he normally would. Now this obviously is going to have changes with the oxygen levels and the carbon dioxide levels. So let's show that in a graph. So here's going to be a graph. And so this here we can talk about saturation. So first let's talk about the saturation of oxygen. So normally, so before your hypoxic ventilation response, we obviously have a low amount of oxygen. But once you start hyperventilating, the amount of oxygen is going to increase, and you will get, let's say, almost to 100% saturation. Actually, we won't leave numbers that might make it complicated, but you do understand that the amount of oxygen will increase. But what happens to the other gas, such as carbon dioxide? So as you start to, so let's just say your normal amount of carbon dioxide is here, usually around 40%, but we're going to kind of exaggerate everything. So what will happen is, when you start hyperventilating, the amount of carbon dioxide in your blood is going to start decreasing. So let me actually erase this. So you actually get a decrease in the amount of carbon dioxide, but you get an increase in the amount of oxygen. And that's just because you have increased ventilation. So this is just due to increased ventilation. You begin to blow off carbon dioxide. Now, here's what you need to remember about carbon dioxide. Carbon dioxide gets turned into carbonic acid. So when you lose carbon dioxide, you're also going to be decreasing acidity. So decreased CO2, decreased acidity, all because of increased ventilation. And increased ventilation leads to an increase in oxygen. So when you have low acidity, well, what happens to your pH? Your pH is going to, you're going to increase your pH, and that's going to lead to alkalosis. So as long as you're able to hyperventilate, you can maintain your oxygen at an appreciable level. However, you will eventually get hindered. This process will get hindered because of the low carbon dioxide level. And now let's talk about how this low carbon dioxide level eventually stops this hyperventilation. So when we were talking about the aortic body and the carotid body, these were primarily responding to oxygen. But in the brain here, right in the medulla, in this area here, this is called the central chemoreceptors. So chemoreceptors, whereas these are called peripheral chemoreceptors. So peripheral chemoreceptors kind of respond to oxygen here, but central chemoreceptors respond to carbon dioxide, specifically carbon dioxide in the CSF. And to be completely accurate, they don't necessarily respond to carbon dioxide, but actually respond to the acidity. Since carbon dioxide gets converted into acid ions within the CSF, and the CSF really doesn't have any other source of hydrogen ions, it indirectly monitors CO2 through the actual hydrogen ions. So as you increase the pH and you have alkalosis, you're going to start having a decrease in hydrogen. When you get a decrease in hydrogen, this will cause it to stop ventilation. So when you stop ventilation, what's going to happen? this physiological acclimatization that you had will actually start to go back down, and your carbon dioxide will go back up. But if you go back down, then you're going to actually have low oxygen here. So you actually kind of undid the benefit that you had from hyperventilation. So what's the solution here? So of course what we'd want to do is we want to keep oxygen levels up, and we want to keep the carbon dioxide levels up as well, to prevent the central chemoreceptors from blocking the effect of the aortic and carotid bodies. So what you can do is you can try to reduce the alkalosis, or you can try to reduce alkalosis. So how do you do that? This is done with the renal system. So what the renal system will do is it will, so say for example, because we're in alkalosis, we have a high number of bicarb. So what the kidneys can do is it can slowly start to excrete bicarb, and so you'll decrease the bicarb level here. When you decrease the bicarb level, you're no longer going to have low hydrogen, you're going to have high hydrogen here, and you're going to bring the, let me erase all this here. You're going to bring the carbon dioxide back up higher. That's going to stop the negative effect of the chemoreceptor here, allow the positive effect of the peripheral receptors, and then you can go ahead and increase your oxygen level again. So the kidney here can pretty much, the way you want to think about it, is the kidney here can stop the inhibitory effect of the central chemoreceptors. Here's one caveat though. It takes time to do this. The individual needs to slowly excrete this out through urination. And so this will take anywhere between 24 to 48 hours, depending on the person and how well hydrated they are, to do this. And so this is why acclimatization takes some time. It doesn't happen right away, because you need to go ahead and excrete all that extra bicarb to allow this carotid body and aortic body to overcome the central chemoreceptors. Now, as a part of acclimatization, there are some other changes that occur. In particular, you get some circulatory changes. So what is also happening is you're getting increased sympathetic activation. And this is just because of the fact that you have that low oxygen level. And so when you have increased sympathetic activation, you're going to increase your cardiac output, you're going to increase your blood pressure, the heart rate will obviously increase, and so will the venous tone. So the individual climber, he also needs to counteract all these effects. And this effect is counteracted by this renal change as well. So remember, we were talking about one of the ways that you can solve this problem that you have over here with the central chemoreceptors is by losing a lot of bicarb. Well, that's called bicarbonate diuresis. So this bicarbonate diuresis not only helps rid the body of this unwanted bicarbonate, but it also helps get rid of some of the some of this intravascular fluid. So this is going to decrease the intravascular volume, and that's going to help offset some of this hypertension and circulatory symptoms that you may have. What also begins to happen is you get a decrease in intravascular volume. Because you have hypoxia, your body will also react by increasing the erythropoietin. Again, something that's also caused by the kidneys here. So you can see kidneys play a very prominent role here. So when you increase the erythropoietin, it takes about 10 to 14 days, but you get an increase in RBC production. So as you can see here, you have increase in RBC production, decrease in intravascular volume. What does that lead to? Hemoconcentration. So your body starts to concentrate the amount of blood that it has, and this actually helps increase, this will increase the oxygen carrying capacity of the blood overall. So not only are you going to be breathing much quicker, but you're going to have a higher concentration of RBCs to take up whatever amount of oxygen that will be in the lungs. So this is another acclimatization effect. Now, this generally will help. Actually, before I get to that, let's talk about the oxygen dissociation curve. So oxygen dissociation curve is a graph here that shows how strongly the RBC attaches to the oxygen at a specific pressure. So here we have the different pressures of oxygen that's around, and then here's going to be the saturation of oxygen, and of course the maximum saturation is going to be 100%. So generally the curve is going to look sinusoidal. So now one of the effects that occurs because of decreased hydrogen ions or alkalosis is you get a left shift. And so what left shift means is it's going to attach to that the oxygen even stronger, and that's something you don't want. You actually want the hemoglobin to release the oxygen more quickly so that it can go into the tissue. So the way your body will respond is it'll increase the production of 2,3-DPG. So it increases the production of 2,3-DPG, and that'll right shift it there as well. However, the only issue is this is only going to be helpful when you're around less than 4,000 meters. When you're above that, this 2,3-DPG is not going to be enough to maintain it in the center, and so you're going to tend to get a left shifted curve after 4,000 meters. So that's something to keep in mind as well. And finally, somewhat anecdotally, we can also say that the hypoxic inducible factor 1 alpha also increases angiogenesis. And so what angiogenesis will do is it'll allow more blood to be carried to the actual tissues, and this will increase the blood flow to the tissue and oxygen delivery. So that's another effect of hypoxic inducible factor 1 alpha. So now let's change our attention to the epidemiology of these high altitude illnesses. So epidemiology and risk factors, it tends to affect all ages and even any fitness level. So just because someone is more athletic or younger doesn't necessarily mean they'll be better at they'll be better able to acclimatize. So it's very hard to predict who will get high altitude illness and who won't. So there does tend to be some involvement genetically. I guess some family members tend to maintain their oxygen levels better than others. However, the biggest risk factor is the rate of ascent. So the faster someone ascends, the more likely it is that they will get these acute altitude illnesses. Some drugs can also increase the likelihood, such as some sedatives, hypnotics, and drinking alcohol. Finally, some comorbidities that we can talk about. This can be COPD, some restrictive lung diseases, cystic fibrosis patients, pneumonia patients, and even pulmonary hypertension. But what's interesting is there are some conditions that are not associated with altitude illnesses. That's one of them is going to be asthma, which actually can improve, and the other is going to be anemia, which can also improve with elevation. So that's something interesting to point out there. So now that we've kind of talked about epidemiology and the physiology, let's go into the first condition, which is going to be the mildest of the three, and this is going to be acute mountain sickness. So acute mountain sickness. So the first thing to know about this is how will it present. So the presentation of this condition is what you're going to find is there's going to be a person who is not used to going up, mountains, and this person recently ascended a mountain, and these persons are generally not adapted. And so, just real quick, what does adapted mean? Adapted means some individuals may actually live in high altitude areas for many generations, and so genetically they have different types of lungs that can handle these high altitudes much more easily. So it's going to be someone who's not used to these high altitudes who suddenly ascended fairly quickly. So that's the common presentation that you'll get. What type of symptoms will these patients have? Generally, it'll kind of be like an alcoholic hangover. So these will be symptoms such as headache, fatigue, nausea, vomiting. So they just generally won't feel that good. They kind of feel groggy. And this can be, anywhere from mild to quite debilitating. So it can really affect, how they're focusing and they're moving around. Any lab work you do, they'll all come back normal, even down to the vital signs, CBC, oxygen, everything will be fairly normal. So, nothing in lab. So again, this is fairly mild, and it hasn't gotten so severe yet that you would see any changes in lab work. So if you do get a patient like this, how do you want to treat it? The first treatment that you want to try is going to be some sort of conservative treatment. So this means things such as no longer ascending, so no further ascent by the patient. You want to try to decrease the physical activity as much as possible, and so this means no carrying of a backpack or any of the other materials. So perhaps, if they're with someone, they can help carry their load for them. Now, just by doing these two things, most individuals will acclimatize by 24 to 48 hours. By that time, like we've talked about, they've kind of lowered that CO2 level, the bicarb level with urination, and so they can go ahead and compensate. However, you may want to give some symptomatic relief. If they have a severe headache or pain, you can give them some aspirin or, even acetaminophen as well. So that's the conservative management. The other thing that you might want to consider is descent. And this you want to consider if they're not improving. And you want to keep descending until they get better. And actually, let's also mention, if they have any neurological symptoms or symptoms of pulmonary edema, then you definitely want to just skip the conservative management and have them descend right away. And again, how low? Well, just keep going until they start to feel better and kind of wait there, again, acclimatize, and then they can start moving up again. What you can also do is you can give them supplemental oxygen. Generally, you want to give about 2 to 4 liters per minute, and you can give it to anywhere from between 15 and 20 minutes. And sometimes you can just give it at night, because again, at night is when you become you hypoventilate, and so that can decrease oxygen levels. So you can make sure to give them that. And supplemental oxygen can sometimes be an alternative to descent, so that's something interesting to remember as well. Finally, you can also give hyperbaric oxygen. And supposedly they do have portable and even inflatable hyperbaric chambers, which I guess are available in those areas. So that's going to be your treatment for acute mountain sickness. Next, we're going to go ahead and we'll change our attention to high altitude cerebral edema. And again, the mnemonic or the acronym for that is HACE. Edema. Okay, so HACE. So this will start off as acute mountain sickness. However, what you'll start to notice is there's going to start being onset of some cerebral dysfunction, and oftentimes this is going to be mistaken for exhaustion. So you'll just assume the patient is just exhausted. However, they're undergoing actually cerebral edema. And what you'll generally find is it'll occur 2,000 to 2,500 meters after symptoms of AMS. So some consider HACE as just a more severe AMS. So depending on how you want to look at it. So what will be the symptoms? You will get neurological symptoms such as ataxic gait. So the person won't be able to walk in a straight line and do certain things. Decreased mental function, and it can also lead to a decrease in the level of consciousness. So they'll start to get really tired and sleepy. Labs, you do get some lab changes. First of all, your LP will show an increase in opening pressure, and they will start to show signs of hypoxemia, especially on pulse oximetry. So that's kind of two things to look for. CT, you will start, of course, you'll see cerebral edema. That's what the condition is, and so that's what you'll see on CT. What is the treatment here? So as soon as you see a patient with this treatment, you just want to descent. You can give them, like some oxygen and, hyperbaric, but descent is your definitive treatment. You want to try to do that as much as possible. However, these patients can become comatose, and if that is the situation, then you want to immediately secure the airway to make sure they don't stop breathing. So that's important on that. So that is HACE. Now we can start talking about high altitude pulmonary edema, which is the acronym here is going to be HAPE, and I'll actually write that here, HAPE. So how does this start? Well, the patient will begin to have a subtle, non-productive cough, kind of like an upper respiratory tract infection. They'll get a little bit of shortness of breath with exercise, and generally it'll begin 2 to 4 days at a new altitude, and it's going to be more severe at night and with severe exercise. So you can see that it kind of starts off kind of insidiously. However, eventually it can progress, and so then they can get like a frothy sputum which has some frank blood in it. They start to get increased exercise intolerance, and when you check their pulse oximetry, they are hypoxemic, and this is definitely going to be life-threatening. So when you start to see these signs, you really want to react very quickly. These patients will also have tachycardia, so they're going to have the high heart rate. They're going to have tachypnea as well, breathing very fast, of course, because it's pulmonary edema. On auscultation, you're going to get your inspiratory crackles. Specifically, it'll start in the middle lobe. However, after a while, as the condition progresses, the crackles will be more diffuse. So that's another sign. And again, this is general signs for pulmonary edema. I just want to mention them to just be thorough. On pulse oximetry, one thing that you'll notice is the oxygen will be about 10 points lower than expected, and it'll improve with supplemental oxygen. So that's a very important point to highlight there, that it does improve. Imaging, on chest x-rays, one of the imaging modalities you can use, you'll just see a patchy infiltrate. Again, it's pulmonary edema, so that's what you'd expect. And on ultrasound, you can get, you'll find extravascular lung water. And again, the pulmonary edema, that's all it is, right? Extravascular lung water. So you will see that. So EVLW is what's the acronym for that. So how do you want to treat? So when you're trying to treat this patient, one of the first things you want to do is decrease the pulmonary artery pressure, so you can get that blood flow going, and you also want to try to decrease the physical activity that the patient is undergoing, and decrease the cold. So one of the ways to decrease the pulmonary artery pressure is to give them supplemental oxygen. Supplemental oxygen, what it will do is it'll cause vasodilation and of all the arteries in the lungs, and so that can help absorb some of that fluid that's going through. And so decreasing physical activity and cold, just rest and stay warm. So that's pretty straightforward. You do want to try descending as well, at least 500 to 1,000 meters. That's the general recommendation. Hyperbaric chamber is an option, so that's something to keep in mind. You can use CPAP. This is going to be pretty unique for HAPE, not for the other two. And there are some pharmacological interventions. And so your pharmacological interventions, again, are aimed at kind of dilating the arteries. So this could be nifedipine, which is a calcium channel blocker, sildenafil, which is a phosphodiesterase antagonist, and you can even use a beta agonist. However, this has been questioned, but some people have recommended it. Finally, we'll talk about prevention. So how can a patient comes in and he wants to hike or climb a mountain, what kind of advice can you give to prevent this conditions? So first, you want to tell them you want to do gradual ascension. So you don't want to go up too quickly. You want to give time to acclimatize your body to what's going on. And so there's a lot of advice, but overall, just remember, climb high, sleep low. That's the motto that climbers use. So you climb up, and when it's time to sleep, you go down a little bit, and then sleep there. So that's one way to do it. You can also do pre-acclimatization, and so this can be maybe living in a high altitude place for a while, or you can even simulate a hypoxemic environment. So that tends to help. And there are some medications. The medications are generally given to people who may have some risk factor. And so again, nifedipine, calcium channel blocker, azathioprine, and dexamethasone are all different medications that are oftentimes given. So this is the topic of high altitude illnesses. Hope you guys found this beneficial. See you guys in a future video. Bye-bye.